Good morning, and thank you for joining us all today. Welcome to another webinar in our 2025 series. We hope you're enjoying the webinars this year as they've been specially requested by stroke survivors. We still have a few more to go, and we hope you'll join us for those future webinars. If you wish to watch any of our previous webinars, or indeed this one that we're doing today again, if you go to our website and select stroke information, a drop-down menu will come up and you'll see webinar library on there. So just click on that and all our webinars will be listed there, ready for you to watch. And as always, we welcome your suggestions for topics for next year. And you'll have a very, very short feedback questionnaire pop up at the end of this webinar today. And there's a section to leave your suggestions for next year as well. Or if they pop up at another time, just email us at info@differentstrokes.co.uk. So today we are being shown how to identify red flags in the prevention and treatment of stroke. And presenting this webinar, we're lucky to have Laura Barlow, Senior Associate at Bolt Burdon Kemp, who will explain some of the common failings she and her colleagues in the adult brain injury team come across in the prevention and treatment of stroke. And there'll be an opportunity to ask Laura questions today. If you'd like to ask Laura anything, just pop it in the Q&A box. We also have a chat box, and we would request it if you want to chat to each other or say hello or say where you're watching from today, please use the chat box, but put any questions in the Q&A box because we might miss them if they're in the chat box. And if you think of a question that you want to ask afterwards, we're more than happy to take an email from yourselves and we can pass it on to Laura and hopefully be able to answer it for you. So just before I pass over to Laura, just a few housekeeping things. We are recording this webinar today, but the only people that will show on the recording are myself and Laura. You'll be all pleased to know. So if you're sitting in your pajamas watching this morning, you are safe. There's, as I've mentioned, the chat function and the Q&A. As I say, I can't stress enough, put any questions in the Q&A box and we will pick them up at the end of the webinar. And now, without any more further ado, I'm going to hand over to Laura to do a presentation. Good morning, Laura.
Good morning. Thank you, Sheila, for the introduction, and thank you to Different Strokes for the opportunity to present this webinar. Also, thank you to those who are attending. I just need to share my screen and then I'll get going. Okay. So hopefully that everybody can see the start of the slideshow. So can you see that, Sheila? I just want to check that.
Yes, it's fine.
Yeah, okay, brilliant. Thank you. As Sheila kindly mentioned, I'm going to speak today about how to identify red flags in the prevention and treatment of stroke. So the team that I work in, we deal with all kinds of brain injury cases, but we do come across some cases where people have had a stroke and there may have been problems with the care that they received either around the time of the stroke or sometimes years before. So I'm going to just give you an overview of some of the things that we see in our team that might be helpful to you or interesting. So I just go, I don't know why it keeps sliding down, but here we go. These are the things that I would like to cover. So first of all, some of the common failings that me and my colleagues have come across in cases that we've worked on to do with strokes and the prevention and treatment of stroke. I'm going to talk about some of the, I'm not sure why this keeps sliding down, sorry, some case examples to illustrate those failings, and also how compensation has helped our clients access specialist rehabilitation equipment and support. And there will be an opportunity at the end to ask any questions. So, first of all, when might a compensation claim for stroke arise? There are three broad categories that I've sort of split this into. First of all, where there's been a failure to either prevent a stroke from occurring in the first place, or in some circumstances, even causing somebody to have a stroke. The second would be failure to diagnose or treat TIAs, so that's a transient ischemic attack. Or a mini stroke. So that's often like a warning for something bigger might happen soon. The third one is coming a bit later, failure to diagnose or treat a stroke that's more of a major stroke. So, first of all, failing to prevent a stroke or causing a stroke. So, some of the cases that we have worked on concern failures by generally sort of like primary care practitioners to either check blood pressure or to monitor blood pressure. And there can also be problems where blood pressure has been monitored to manage blood pressure effectively. So, whether that's providing medication or through advising on lifestyle changes, it can be both of those things. But if somebody has presented, for example, to a nurse or a GP, and they have significantly high blood pressure that needs treatment and that isn't treated, that can cause problems further down the line. So failing to prevent a stroke, a few more things on blood pressure. So many of you probably know blood pressure, also called hypertension, is one of the biggest risk factors for stroke because it causes damages to vessels, and then you can get this sort of stiffening of the vessels, and they can, which sort of gets a clot on it, and then that can break off and go into the brain, or you can get a tear in a blood vessel, and that causes a hemorrhagic stroke. And some of the risk factors for high blood pressure are things like high salt consumption, obesity, inactivity, alcohol, smoking, and also the oral contraceptive pill and pregnancy. Both of those things can increase risk of stroke. So these are the kind of things that when blood pressure is high, that you might expect a medical practitioner to be looking at those kind of risk factors and helping people to manage those if possible. Then, so we've talked about, I've gone through some of those things already. So failing to check blood pressure when somebody's on the contraceptive pill is something that we've looked at in previous cases. And like I said before, if somebody has a very high blood pressure reading or even borderline high, there usually needs to be some kind of follow-up. And it sometimes can just be watch and wait if it's not very high. But other times there will be a requirement for medication. And as I say, we have dealt with cases where there's been a failure to provide medication, and that's further down the line. So, as in a couple of years down the line, resulted in stroke. So, just one of the examples. One of a previous client of mine visited a nurse who saw that she had high blood pressure. She was referred to the GP who advised on lifestyle factors, but didn't arrange follow-up monitoring of blood pressure. And then almost 2 years later, she unfortunately did have a stroke, and had blood pressure been treated much earlier, that could have been avoided. We also have looked at cases, like I said, about the contraceptive pill, where pill checks haven't included blood pressure reading, and that person has later gone on to have a stroke. The second part of part one of my 3 points was where a medical professional or a team of medical professionals has actually contributed to causing a stroke. So there are a few ways that we see this happening in cases that we've looked at. So the first one of those is where inadequate anticoagulation has happened following a medical procedure, or in some circumstances following childbirth. We've also seen cases where anticoagulation for somebody who's already on anticoagulants has been removed when they go into hospital, and it shouldn't have been removed, and then they've gone on to have a stroke. And finally, we've looked at cases where, and hopefully this happens very rarely, but cases where an air embolism has caused a stroke. So I think I've got some examples of this on the next slide. So yeah, so the first one, our client who had orthopedic surgery, and the anticoagulation that he was provided following the surgery wasn't adequate. So sometime later, he had a stroke, and it was related to the anticoagulation. Contributing to his case, he also had a hole in his heart called a PFO, and that was undiagnosed at the time, which is quite normal because people often don't know that they have those, but that increased his chances of having a stroke. And then we have two clients who were both admitted to hospital, and there were anticoagulation failures in hospital where they were on anticoagulation and that was withdrawn during a hospital stay. And again, that led to them having a stroke. And the final one we did, I said that hopefully this is very rare, but we did once have a case where a client of ours had been injected negligently with an air embolism that travelled to her brain and caused a stroke. So hopefully that's something that we don't like to come across any of these cases, but that one's a really, really, really serious failure. So the second, so that covers failing to prevent a stroke and potentially even causing a stroke. The second sort of category of stroke cases that we see is where there's been a failure to diagnose warning signs of a bigger stroke. So I talked about at the start TIAs and mini strokes and those warning signs being ignored. We also have seen examples of radiology being misreported. And unfortunately, for younger people who have a stroke, we think there's sometimes a view that people are too young to have a stroke, and their stroke not diagnosis it's not even considered in the list of possibilities. Another thing that can sometimes contribute to a failure to diagnose those early signs is where there's atypical symptoms. So I just wanted to talk about a client of mine that, oh, sorry about this, it just keeps on. I don't know why this is sliding back and forth between the slides. Stay there. So yeah, my client Andy, who was 24 years old. Oh dear, I'm just going to try and switch off my mouse because I think that might be the reason. No. My client Andy, 24 years old, he attended his GP with right-sided weakness and difficulty communicating. And his GP had never met him before. He was in the UK as a student. And instead of considering that his speech difficulties might be due to a stroke, she queried whether he had learning difficulties. Um, she didn't know him. There was no record of learning difficulties on his medical record. So it was quite a bizarre conclusion to come to. But that's the conclusion she came to. She didn't make any kind of urgent referral, even though he had stroke symptoms, and she referred him for blood tests. So what was happening at that point is that he was having a minor stroke at that appointment, and then 3 days later, he had a really major and catastrophic stroke, which left him in hospital for a long time. He needed significant rehabilitation and he was left significantly disabled. Um, I'm just going to try and stop these slides from moving around. I really don't know why this is doing that. Please bear with me for 1 second. Um, see if that's made any difference. No. Um, so in that case, here we go. I'm just gonna, oh, in that case, my client the medical evidence that we received said that he should have been referred to neurology or the emergency department on the same day. And that had he been referred on that same day, he would have been put on medication in time to prevent the clotting and the further stroke that he had. So there was an opportunity for his GP to prevent that further stroke, and it was missed. Um, so moving on to the final section of the 3 points that I wanted to look at. This is where there's been a delay or a failure to treat a stroke once it's already happened. So I'm talking about the one sort of event. If there haven't been any warning signs or if there have been warning signs and they haven't been picked up on. Um, so it can be a bit more difficult to prove that the outcome would have been different when you are at that point, because if somebody's already had a stroke and there is some delay, we can't always show that treatment that they might have had would have made a significant difference to their outcome. There are some things that might make a difference, like thrombolysis and thrombectomy. But the medical experts that we speak to often tell us that thrombolysis and thrombectomy are not the sort of wonder drugs or the wonder treatment that sometimes they have been made out to be. They can make a difference, but it's not always enough of a difference for us to say that on the balance of probabilities, they would have made a better recovery if they had been treated 1 or 2 hours earlier. So yeah, I wanted to, so that covers the um, right. I don't know why this keeps moving. I'm so sorry about that. That covers why those 3 points that I wanted to talk about. So where there's either a failure to prevent or a medical practitioner causing a stroke, there's been a failure to spot early warning signs of stroke and act upon those, and then finally where there has been a stroke and there's a delay or a failure to treat that. So how compensation has helped our clients. So here I wanted to talk a little bit about some the reasons that people contact us. Um, Obviously, we deal with cases, and the eventual outcome of successful cases for us is compensation. But lots of people also want answers because you don't always know exactly what happened, and it can be nice to know why things happened the way they did. Secondly, accountability. Um, if something did go wrong and you want the people who were responsible for that to be held accountable, that ties in a bit with justice and feeling that if something did go wrong, that there has been justice. Um, and then one of the prevention, lots of people say this to us about how um, they don't want this to happen to somebody else. So this happened to me and I can't change that, but I want to make sure that this doesn't happen to anybody in the future. And we hope that through what we do and through defendants paying compensation to clients who have been injured, that hopefully that does feed down sometimes and prevent further failures. The final two, quality of life and peace of mind, are the two that I wanted to focus a little bit more on. So, quality of life. In our cases, where there's been an admission of liability, usually, it's very difficult when there hasn't been an admission of liability, but where there has, we will always consider whether an interim payment should be requested for rehabilitation. So, if a defendant has admitted liability and they're going to be paying damages to a client, we are strong believers that rehabilitation, whenever you can get it, is a good thing. So we would try and get an interim payment as soon as possible for rehabilitation, also for financial support for our clients. For example, sometimes our clients have lost earnings because they can't work after their stroke and they've got a mortgage to pay. So if there is a possibility of an interim payment, you can ask for interim payments for that kind of financial support as well. And then for practical support. So if somebody has an accommodation requirement following a stroke that they didn't have previously, so they might need level accommodation or other adaptations. We can request interim payments for either temporary rental accommodation and sometimes in bigger cases for future accommodation for the rest of somebody's life. Interim payments can also, as I said, cover rehabilitation. So if speech and language therapy is needed, if physiotherapy is needed, occupational therapists, and in cases where there are multiple problems, people might need a case manager to sort of pull all that together and manage it. And then if somebody lacks capacity, they might need a professional deputy to assist them with their finances. So interim payments can cover any immediate needs for people who are in the middle of a case. And we don't yet know what the final outcome of the case is going to be. So they're a really useful tool, and we apply for interim payments a lot on our cases. Um, so following on from that, I wanted to talk a little bit about peace of mind. So when a case is concluded, there are two main ways that cases are settled. Either a claimant will get a lump sum award, which is the whole of their compensation in one go. But where somebody has ongoing needs for usually care, case management, therapies, things like that, that it's something that's going to be needed for the rest of their life, we will often look to settle the case on, so there's a lump sum element, but then you get periodical payments for the rest of your life. So every year there would be an annual payment to cover the cost of care and case management and therapies and any other support that they need on a lifelong basis. And one of the best things about periodical payments is that the payment is index linked to the cost of care. So as the cost of care increases, so does the payment. The other really good thing about periodical payments is that they continue for the rest of somebody's life. So with a lump sum, that's just based on people's best estimate as to how long somebody's going to live. And if people outlive their life expectancy, the lump sum, which would be invested, might not last right until the end of life, whereas a periodical payments order would, because it would always be there until the person dies. Um, the other things that I just talked about was about adapted homes. So if people need adaptations to their house, a compensation claim can help them with that if they're successful, and financial protection and knowing for the future that somebody is going to have that financial security for the rest of their life. So, last few things. I just wanted to talk briefly about when it would be appropriate to seek, especially legal advice, if you have any concerns about care. Um, I mean, really, I think anybody who has a concern about care should, it's not going to hurt if you ask somebody whether they think that there is something that possibly went wrong. And we are always happy to speak to people, even if it turns out that, there isn't anything that would have changed the outcome or care that was below a reasonable standard. Um, so I just think that anybody who's got a concern should ask. And when, really as soon as possible, because I'll come on to talk about limits in a second, but the sooner you can contact somebody and start asking questions, the better. So time limits, also known as limitations. So there are pretty strict time limits for bringing a claim. So the basic rules are that for an adult, it's 3 years from the date that you um, either knew or had some knowledge that you were injured as a result of either a negligence or obviously in personal injury cases the accident, but for negligence 3 years from when you knew or suspected that there was some kind of something that went wrong. And for a child, if a parent is bringing a case on behalf of the child, that needs to be done by the 18th birthday. But then once they turn 18, they can start a claim themselves up until the 21st birthday. Now, there are exceptions to those rules, and the main one for the cases that I work on is where somebody lacks capacity to bring a case by themselves. So if somebody has quite a serious injury and they don't have the cognitive ability to be able to instruct a solicitor, give instructions on their case, without somebody else supporting or doing that for them, then they may lack capacity. And we would get that assessed by a medical professional. But where somebody is assessed as lacking capacity, the time limits don't apply. However, we would always say still contact solicitors as soon as possible, because defendants can try to dispute whether somebody has capacity or not. So they might not agree. We might say our client lacks capacity, but they may say, oh, your client has capacity, so it's a 3-year time limit. So we're always very careful about that. So the main rule is 3 years. Um, Actually, I just want to go back to that slide, because the point about 3 years from knowledge is an important one, because the cases that I talked about at the very start of blood pressure readings at a GP that might not have been picked up on, and then somebody has a stroke, I don't know, 2, 3 years later, the negligence obviously occurred some time ago if it was negligent care, but the person wouldn't know that until something had happened that caused them an injury. So the date of the stroke, you would look at that as the start, even if the negligent care was before that. So a few closing thoughts. Like I just said, substandard care might have happened years before the stroke. And so I do get inquiries where a person is asking, I had a stroke and I think that there was a delay in getting me to the hospital or treating me when I got to the hospital. But I always, if I'm looking at medical records, will look back and see if there's anything that happened prior to that that might have been a problem that nobody knew about at the time. So I do think it's important to look back as well as to what happened before the stroke. And if you have any uh, doubts or suspicions, I would say there really is no harm in just asking the question. And good solicitors will give a free initial call. And generally, for these kind of cases, there will be no win, no fee funding arrangements, which is what pretty much all of our clients have in place for funding their cases. So there isn't anything to worry about. You don't have to feel like, well, if I contact a solicitor, I'm going to get a bill. That's not how it works. And obviously, all of that would be discussed in detail, and it is whenever we take on a case. But for some initial advice, we are very happy to speak to people, and that there isn't any harm in just asking that question. Um, so yeah, that brings me to the end. I'm so sorry about the slides just moving around. I don't know how distracting that was for you, for all of you. It was really distracting for me. But I've never had that happen before. I don't know why it was happening, whether it was a problem with my mouse or something. But if anybody does have any questions, either feel free to ask now, or if you want to send an email to Sheila or Austin, or I also, on the next slide, I've got my contact details. So if you want to contact me directly, that's fine as well. I'll just put that there. And then I can stop sharing my screen. There we go. No more slides to be flying around.
Thank you for that, Laura. If anybody needs a copy of any of the slides, between us, we can
Yeah, I've
provide
sent
them.
them
So
to Austin.
yeah, so don't worry about it. We had a couple of questions come
Okay.
in. You actually answered one because one was about a 3-year time limit, which
Yeah.
we've gone into already. The other one, I'll read it out to you. Trying to weigh up if it is worth the emotional strain of pursuing a claim and having to relive it.
Yeah.
What are typical levels of compensation and what tends to be the upper limit?
Um, well, that's a really difficult question to answer because it depends on that person's circumstances. For somebody who was a really high earner, who lost their ability to earn and had 40 years ahead of them, their claim would be worth probably millions, but it all depends on personal circumstances. Also, if somebody had, like, for example, really high care needs and needed 24-hour care from two people, that creates a lot of value in the case as well. So, I mean, cases, if somebody suffered a serious injury, I doubt there would be a claim that's sort of like less than six figures, but it's from there to basically anywhere. It's really hard to give anything precise without some more specific details. I think the start of the question was about the emotional turmoil and having to relive it, which is a consideration that I think people, yeah, it's a really difficult one because you do, through the process of bringing a case, medical experts have to assess our clients to say what are their ongoing problems, and there is an element of having to go through what happened at the time. However, there is quite a lot of work going on at the moment to assist with that and avoid re-traumatization of claimants through the litigation process. And it's something that I'm quite actively trying to do on my cases now, because it is well recognized that through like medical assessments, going through it again and again is can be quite traumatizing, because it was probably the most traumatic thing that ever happened to that person in their life, and then having to go and see expert after expert who all ask the same questions, and you have to kind of go through it again and again. It's really difficult. So for clients now, I'm starting to put into instructions to experts that all the information's here. Unless you absolutely have to, please don't ask about the incident itself. I mean, sometimes it can't be avoided, but we are doing things, and there's a group of barristers that have put together some guidance on that as well. Also, like as a firm, our approach is to try and make everything as unstressful as possible. I mean, it's the, the process of bringing a claim can be somewhat stressful, because you have to talk about was there a mistake or not, and then you're talking about what future needs are. But we as a firm, we just try and support people through that and try and make it as easy as possible. And I think we have a very sort of empathetic and supportive approach, and we do things like teeing up our experts to try and not create any unnecessary trauma following the event. Sorry, that was a really long answer, but there's quite a lot of things that came out of the question. I hope that answers it.
Thank you, Laura. Right, we've got it looks like two more questions, but I think it's all one story. So bear with me while I read
Okay.
it
Yeah.
out. My partner was misdiagnosed with a hemiplegic migraine when he was actually having a TIA.
Yeah.
His record stated that the stroke team didn't want to see him, but later denied this, and he was discharged the next day. He then suffered a full stroke at home. Could
Yeah.
this situation potentially constitute medical negligence, and what steps should we take to explore legal accountability? The ward manager did come round and admitted that it was a mistake on their part, and
Yeah.
his stroke could have been avoided if they'd spotted it when he first came in. They're opening up an investigation into this, but there's been no update since, and his stroke was 7 weeks ago yesterday.
Oh, well, I'm so sorry to hear about that story. And I guess they're still in the recovery phase at the moment and trying to get to terms with what's happened. That very squarely sits in that second category that I was talking about, where there's been a warning sign, and it sounds as though, from what the hospital have said already, that there may have been a failure to act upon that. And also, I think they said that, from what you just read out, that the hospital have said that if they had acted, that he wouldn't have had the further stroke. So it's definitely something that I think should be investigated.
Okay, thank you. And
Obviously, it's very recent as well, so it's not the
yes,
time. It is
yes.
plenty of time to investigate as well.
Okay, we've got another one here. Is it worth looking into if someone has had a stroke, even though being on BP medication for over 30 years? Why has this occurred?
Hmm.
Could this have been prevented, or is it not worth pursuing?
I think when long-term blood pressure medication, I think it should be reviewed regularly. I think the question there would be, was the medication being reviewed, and was it at an appropriate level? Like, I don't know the answer to that question. You would have to get a GP to look at the records and say, this person's on long-term medication and they should have had reviews every, I don't know what it is, maybe every year, and whether the levels were sufficient or not. So I think There's a possibility that there could be something there. I think that's one that you have to get an expert to look at before you know whether there is anything anything in it.
Okay, thank you. It's seems to be it so depends on in totally
Yeah, I
individual
think for every,
circumstances, doesn't it?
yeah. And for, I mean, even when you just say, for example, something like, well, I had high blood pressure, it wasn't treated, you still have to look at the timings and the,
Mhm.
um, whether the medication would have made a difference by the time the person had a stroke. It's very, it, in terms of the actual liability side of things, so whether there was a failure and whether that made a difference. And also quantum, it's highly specific to the individual circumstances of each case, which is why you have to get expert reports and it's very difficult to make broad generalizations about whether a case would succeed or wouldn't.
Yeah, it's a tricky one to just
Yeah.
answer off the cuff, isn't it?
Yeah.
And I think like this next question as well. I don't know if you maybe want to read this, Laura. Um,
In the
it,
Q&A.
it's
Yeah.
yes.
Oh, okay. Is this, yeah, I believe my cerebellar stroke, this one. Um, um,
There seems to
oh
be lots of
wow.
bits to
Yeah.
this.
Um, I mean, yeah, there is a lot of different potential aspects to this. Um, I'm just reading the second part as well. Yeah, I think, I mean, I'm very happy to have a chat with the person who posted that question because it looks like there could be issues with anticoagulation, surgical procedure, um, care in hospital. There's lots of different potential things to look at there.
Okay, the person that put that in
Yes.
the Q&A, if you look in the chat, you'll see our email address.
Yeah.
If you send us in an email, then we can pass that on to Laura to have a chat as well. Is there anybody else that would like to ask anything just now? You've got a few more minutes to do it if you do. And there's somebody in the chat. Can you post Laura's contact details again? Could you
Yeah, that's
pop
fine.
your
Shall I just
details
put
in
my
there?
let me just put my
And I'll do ours again as well.
there's my email address.
Okay, so there's several email addresses in there, and I'll put mine in there as well. So if anybody wants to get in touch, please do.
My
Or if you
memory
want to
has
watch this
flooded.
back again and something pops into into your mind, even if you think it's a silly question, that's fine. Somebody's probably asked it before, so don't,
Yeah.
don't be frightened. No question is a silly question, we always say. Um, so thank you very much for
No,
your
thank you. Thank
presentation
you.
today, Laura. And as we say, if anybody wants the slides, we can get them to them. If anybody's got any questions, um, we're just going to end the webinar in a second, and that very short feedback questionnaire will pop up. So thank you to all of you for attending. Thank you so much to Laura as well, and hopefully we'll see you on our next webinar. Thank you.
Thanks. Bye.